Okay, so we'll talk about epidemiology of hepatitis C and HIV co-infection in the United States. I have no conflicts to declare. I do want to thank Dr. Esteban Gonzalez for being the initial slide developer, and I just added a few comments specifically focused on HIV for this talk. And this is our standard disclaimer regarding the use of trade or brand names. I don't think I have any in this slide deck specifically, but just to make the audience aware that any trade or brand name used in this presentation are for training and identification purposes only and do not reflect specific endorsement by the Department of Health and Human Services. The lesson objectives are to identify and understand epidemiologic trends in hepatitis C in the United States, review transmission and natural progression of the disease, and review screening recommendations for hepatitis C. So globally, about 58 million people are living with hepatitis C. That's kind of the calculation, internationally speaking. And there are about 1.5 million new infections occurring per year internationally, so globally, all countries. It is reported at least 290,000 deaths worldwide, mostly from cirrhosis and hepatocellular carcinoma related to hepatitis C. This is the reason why it's such an important goal to eliminate hepatitis C by 2030, which is a WHO goal that we are probably all familiar with. And how are we going to do that? We need to make sure that we're extending treatment with the directly acting agents, regardless of the extent of the disease. Specifically in the US, there are about 2.4 million people living with hepatitis C, and this is kind of a stable range between 2013 and 2019. And to give a little bit of background, so there are around 1.2 million people living with HIV, and then about 15% of these people living with HIV are co-infected with hepatitis C. So that's kind of how these syndemics relate. There are estimated 57,000 cases, new cases per year, anywhere between 60,000 to 65,000 new cases per year are reported in the US. And this kind of number fluctuates over time, but this is kind of the overall range. And in 2018, there were 15,713 deaths attributed specifically to hepatitis C in the US. Hepatitis C is the most common blood-borne infection in the US. And chronic disease develops in up to 85% of exposed, and this is kind of the general population, but this happens way more frequently in people who are co-infected with HIV. And so we know that their liver disease can not only progress more rapidly, so they can develop cirrhosis much more rapidly if they're co-infected with HIV, but they're, and this is regardless of how well controlled their HIV is. And we know that liver disease, especially due to chronic infection with co-infection with hepatitis B, is the leading cause of mortality amongst people with HIV currently after different shifts of kind of morbidity and mortality related to access to antiretrovirals. And then so, although HIV-related mortality has decreased with the availability of antiretroviral therapy, there is still evidence that people who have HIV and HCV co-infection have higher rates of liver-related death compared to those with hepatitis C mono-infection. And then this is the hepatitis C infection is the leading indication for liver transplantation and cause of hepatocellular carcinoma in the US. We know that there's no vaccine for this infection, so we just need to kind of really focus on strategies to reduce the risk of exposure and acquisition. And 50% of chronic infection in the US still remains undiagnosed and 70% untreated. So this is a serious public health concern. This is a representation of what I just mentioned. Unfortunately, there are really high rates of estimated cases of acute hepatitis C that are just underreported for a wide variety of reasons, whether this population is getting access to testing or being able to see a provider to explore their concerns. And this has continued to be a problem over time. When we compare the numbers from 2013, we can see that there's been some improvement compared to 2020, but still, when you compare the reported acute cases versus the estimated acute infections, there's a big gap, a big discrepancy between what it should be. Part of the reason why it's really difficult to tackle these problems. In terms of acute hepatitis C infection cases by age group in the United States, these are the trends over time since the early 2000s. And then so you can see that historically, and it still remains, that the majority of acute hepatitis C infections in the US are primarily focused on patients who are 20 to 29 years of age and 30 to 39 years of age. And this is primarily driven by the opioid epidemic affecting this patient population. So injection drug use remains the main risk factor for transmission of hepatitis C in the US. And spontaneous resolution of acute infection occurs in a minority of cases. So typically, around 20% of these cases with acute hepatitis C infection will spontaneously resolve the infection. This number is actually a lot lower in patients who are living with HIV, where the reported rates of spontaneous resolution is only about 5%, anywhere between 5 to 10%. So for a wide variety of reasons, people who are co-infected with HIV tend to be less likely to spontaneously resolve the infection. And then when we are thinking historically, the 10 years ago, the guidelines didn't support the use of directly acting antiretrovirals for acute infections. That has actually shifted because we know that the likelihood that you are going to spontaneously resolve this infection or cure this infection is actually quite low, and the time frame where you can still kind of remain viremic, then that is a risk for transmission to others. So this is the reason why offering treatment to all patients with hepatitis C is going to be really important to be able to tackle this epidemic. Chronic liver disease develops in most individuals with hepatitis C and can lead to cirrhosis, liver cancer, liver failure, and death. And sustained virologic response, meaning cure, can be achieved in a great majority of cases with antiviral therapy. So this slide highlights what I just described, the natural history of hepatitis C infection. So you acquire the infection acutely, and then about anywhere between, it's really more like 10 to 20% of these patients will reach spontaneous resolution, where the infection is cured just spontaneously. But about more than half of these patients, usually more than 80% of these patients, will eventually develop chronic hepatitis C infection. And this chronic inflammation will lead to fibrosis, cirrhosis, which is the scarring of the liver, and with this, then the development of hepatocellular carcinoma. So around 75% of patients infected with hepatitis C will develop chronic infection, and 65% with chronic infection will develop chronic liver disease. And a reminder that if you have HIV co-infection, the likelihood that this will happen is not only higher, but it's going to happen more rapidly. And then, so historically, when we think about hepatitis C as healthcare providers, we always think about kind of baby boomers, a population that got exposed to hepatitis C due to blood transfusions in the 1960s, and then the inability to detect the virus until 1989. So this was a population that was really a main focus of testing for the longest time. But fortunately, there's been a little bit of a shift in practice where now we really have to focus on making sure that everybody has access to hepatitis C antibody testing, regardless of whether you're a baby boomer or not, especially in the setting of the opioid epidemic being the main reason why patients acquire hepatitis C, especially in the younger population. So about 30 to 70% of patients or people who inject drugs are exposed to hepatitis C and can acquire hepatitis C depending on kind of your specific local demographics. And it's present in about 15 to 35% of incarcerated patients, and also very present in the unhoused population. And transmission of hepatitis C can occur via contact with contaminated blood, primarily needles, syringes, preparation for equipment of injecting drugs. Any part of the equipment can get contaminated with hepatitis C, and this virus is actually very, very hardy. So it's really hard to sterilize equipment that has been previously used, not only equipment, the cookers, water, surfaces, if the surfaces were shared with anybody else. It kind of part of the reason why it's also important to address whether they're using intranasal cocaine, because then there can be some small particles of blood that can contaminate the surfaces, and that can, if someone is using needles, contaminate their needle equipment. So the prevalence of hepatitis C nasal drug users is up to 35% because of this. And hepatitis C has been found in the stems of crack pipes. This is not just related to the needle itself, but like all of these specific factors and portions of the injection drug use practices. And in order to truly eliminate hepatitis C, a hepatitis C contaminated solution, this needs to be heated for almost 90 seconds and reach temperatures of 144 Fahrenheit for the virus to become essentially unstable or undetectable. So it's hard to do this, especially if you're using all these different objects as part of a injection drug use practices. So it's a really hardy virus. It's really hard to eliminate. This slide, again, is a reminder that as the opioid injection epidemic has worsened over time, this has been associated with higher rates of hepatitis C transmission, especially in the youth among ages of 30 to 39 years of age. This is a population that's primarily affected by this. And hepatitis C is more readily transmitted than HIV with a single needle exposure. So less sharing is needed to transmit hepatitis C compared to HIV for whatever reason. It's probably also related to the fact that the virus is hardier, that it just kind of lives in surfaces so much more easily compared to HIV. And the sharing drug preparation equipment will much more efficaciously transmit hepatitis C than HIV. But it's definitely, as I mentioned earlier, a problem that is shared for people living with HIV, where about 15 to 20% of everybody living with HIV are co-infected with hepatitis C. In correctional settings, we see that hepatitis C disproportionately affects individuals in where 1 in 3 inmates in the U.S. have chronic hepatitis C, injection drug use being the most common risk factor, and HCV-associated liver disease is a frequent cause of death. So this is something that they like to ask in the internal medicine and infectious disease boards, specifically the risk of sexual transmission of hepatitis C. And in general, the risk of transmission within heterosexual couples is actually quite low, which you wouldn't really expect. And then so when they've done long-term cross-sectional studies where they have monogamous couples and they follow them over time to look at risk of acquiring hepatitis C. And they've done sequencing to assess concordance. Overall, the presence amongst partners tends to be quite low, and those with concordant genotype, meaning those who actually acquired the same virus, were less than 1% in this specific study. And the maximum incidence rate was 0.07% per year, and the incidence risk, and this was in heterosexual partners, was 1 per every 190,000 sexual contacts. So the risk of transmission through heterosexual practices, this is excluding anal contact, anal intercourse, is quite low. But the risk is higher if you have someone in the relationship who has HIV, or if they're MSM, then the incidence can go up to 4 to 5% per year. And this is part of the reason why it is recommended that people living with HIV and MSM patients get screened for hepatitis C at least yearly. Again, highlighting the exposure risks, we discussed them. Highest risk factors is injection drug use, and this is followed by high-risk sexual exposure, and then surgery exposure and occupational needle stick exposure. So we have highlighted the efficacy of directly acting antivirals against hepatitis C multiple times in this echo. We know that hepatitis C can be eradicated. The current therapy is oral. There's minimal side effects. There's many options for all genotypes of pangenotypic regimens. The majority of regimens end up being somewhere between 2 to 3 months, and at least 99% to 100% of patients achieve sustained virologic response. And this is fortunately also something that we're seeing in people living with HIV. So this is definitely something that is much more achievable now than it was 15 years ago, for example. This is a reminder of the screening recommendations for hepatitis C, which kind of has shifted from that focus of testing baby boomers to now testing everybody. Of course, you're going to test them if they're at risk of infection, if they have past or current injection drug use, you want to test them at least yearly. MSM populations, people living with HIV, you want to test them at least yearly. But if they don't have any risk factors, you still should offer at least a one-time screening for all adults aged 18 to 79 years of age. And this is a USPSTF recommendation. So universal screening is now the way to go, both for hepatitis C and HIV. And then so they say at least one time for people who are at risk of acquiring hepatitis C. Those of us who work specifically with people living with HIV, we know that most grants will recommend for us to retest them every year, depending on factors. So routine periodic testing for people with ongoing risk factors. And then so important to remember that universal access to safe, affordable, effective prevention, care, and treatment services is going to be key for us to be able to eliminate hepatitis C. And the goal is still, this is the WHO goal, to eliminate viral hepatitis as a major public health threat by 2030. And then in order to do that, they plan to decrease hepatitis C cases from 1.7 million new cases and 400,000 deaths in 2015 to somewhere around less than 175,000 new cases and less than 140,000 deaths by 2030. But this is really a daunting goal, and in order to do that, there's a lot of things that really have to happen. We really have to focus in intravenous drug use as the primary source of new hepatitis C infections in most high-income regions of the world. We need to address safer injection practices in order to eliminate hepatitis C, access to strategies that have proven to reduce the risk of transmission. And we know that in order to truly eliminate hepatitis C, you would have to make sure that you're testing and diagnosing at least 90% of all affected patients and treating at least 80% of those diagnosed in order to tackle this epidemic. So in conclusion, hepatitis C and opioid injection are rising in parallel. Prioritization of hepatitis C treatment to achieve cure among high-risk populations should be implemented. And screening and diagnosing hepatitis C in vulnerable populations with integrated care will help us reach that elimination goal. These are the references, and I am going to open it up for questions.